Hi, thank you for being here. We did one previous CME day, and I spent a lot of time talking about the diagnosis of autism. Today, even if some of you are new, we want to just do a quick review of that, enough to make sure everyone's on the same page about what the criteria are for autism spectrum disorder. And then I really want to get into looking at the MCHAT and its usefulness for screening for autism, and how to think about it in terms of how it tracks to the diagnostic criteria. So I have no conflicts of interest to disclose. We've already sort of talked about the goals of the presentation, so let's get into the diagnostic criteria. So I think it's useful to think about the diagnosis of autism as a Venn diagram with two constellations of symptoms, both of which are necessary for the diagnosis. So this is not an either or. Children have to be presenting with both of these. The first of which are social impairments and communication impairments. We'll get into some of the specifics of that in a minute. And then the second are restricted, repetitive, or stereotype patterns of behavior, interests, the uses of objects, or speech, and included in that category also are sensory sensitivities. So going back to that first constellation, deficits in social impairment and communication impairment, there are three subcategories of symptoms, and all three subcategories must be present for the diagnosis. The first subcategory are deficits in social emotional reciprocity. So what that means is that's the back and forth of interaction. So there's lots of ways that we as humans interact with each other and have a mutual exchange. One of the ways is verbally. So by having a conversation, that's a back and forth exchange. When I'm diagnosing autism, I'm thinking of conversation as being more than simply answering questions. If I ask a direct question of a child with autism, it's not unlikely that they'll respond. But to what extent can the child engage in a continued back and forth where there's some building or adding on to what's being said? So that's, when we're talking about conversation, it's more of a ping pong back and forth where each person is contributing a little bit more to the dialogue. There's other ways that we demonstrate social reciprocity. Other examples would be our response to what other people say or do. So if I call somebody by name, I'm anticipating that they'll turn and look toward me. That shows an initiation or an engagement on their part. I'm anticipating if I sort of look to the right or left, that they're going to sort of look with me. We talk about this skill as joint attention. So if I'm looking to the left very quickly and have a facial expression that says like, wow, or look at that, and the other person responds, they're responding to my initiation of joint attention. Other examples of joint attention are more obvious, like pointing, look at that. I'm initiating and I'm anticipating a response to that initiation. We also look at to what extent does the child attempt to initiate with you? So maybe they can follow your efforts to initiate joint attention. To what extent are they trying to initiate joint attention with you? So again, joint attention is an important skill that we're looking for, and it involves the sharing of an interest or the mutual focus on an object together. So that's another component of this reciprocity. So those are a few examples of social emotional reciprocity. Then there's deficits in nonverbal communication skills. Nonverbal communication includes eye contact, facial expressions, gestures, our body language, and sort of our awareness of proximity to one another, and just sort of reading what's the right distance to give another person. These are all aspects of nonverbal communication skills. So with kids who have autism, they may show a deficit in one of these areas. We often think of a child with autism having poor eye contact, and it is true that there's a lot of kids with autism who have poor eye contact. But there's a lot of kids with autism who have, totally acceptable eye contact. So you can't use that as the litmus test. That's one example of where nonverbal communication deficits could happen. It's not the only example. Other examples are pointing. We've already talked about pointing as a tool for reciprocal communication, but it can also be, just at the most basic level, it's a gesture. Other gestures are, we talk about, or we think of, so like descriptive gesture is a gesture where you're describing something. So I was on this roller coaster and it went way up and then it went way down and then it veered to the right. I'm sort of painting a picture for you of that roller coaster using my gestures. So that's kind of a higher order gesture that we expect to see in kids, especially when they get to be like 4, 5, 6 years old and they're starting to have more complex speech. More basic gestures, more informational type gestures are things like nodding your head to mean yes, shaking your head to mean no. I want 2 pieces of candy. Those are examples of other like informational gestures that a child might use. Emphatic gestures, talking with your speech or to the beat of rhythm, or like yes, those types of things. So there's a lot of different types of gestures a person might have. They don't all kind of surface or develop in the same kind of age range, but we're looking for some presence of gestures pretty much early on, all the way through, adolescence and adulthood. You're looking for gestures. Facial expressions is another example. So kids with autism may have a limited range of facial expressions. They may, a parent might share, my kid is either really happy or really angry. I can see those on their face, but everything in between is hard to read. So they may have a limited range of facial expressions, or you can see a kid with autism who has a totally normal range of facial expressions, but they have limited direction of their expression toward other people. The way I think about this is if I see something exciting and I have a reaction to that, I'm having a reaction. It's emotional reaction. When I direct my face toward you, I've turned my reaction into a form of communication. What I'm saying to you is, I'm surprised right now. And so sometimes you'll see a kid with autism who has a big range of facial expressions, but without that directing it toward other people. So there's that, they're missing the communicative piece of the facial expression. So that's another way that you might see glitches in facial expressions, or a mismatch of the facial expression and the situation. So contextually, they're misreading situations, and so their expressions are not matching that. So maybe they're in a setting where maybe they're at a funeral or a wake or something, and everybody in the room has a mournful expression, and the child's just not reading that correctly and doesn't appreciate like what face to match with the situation. So those are different examples of where nonverbal communication issues can kind of become problematic for a kid with autism. Another thing that we look at is the degree to which those things are integrated with each other. So right now, as I'm talking with you, I'm trying to make eye contact with people in the room. I'm using gestures and vocalizations, and they're all sort of nicely fit together, hopefully. Sometimes we'll see a kid with autism who can do all of these skills, but they're really having a hard time with integration. So there are some forms of deficits in nonverbal communication that need to be present for the diagnosis, but they come out in different ways. The final one is deficits in developing and or understanding social relationships. This might look like a lack of interest in friendships, or a child might have an interest in friendships, but be lacking in understanding of how to maintain and develop those. Moving on to the other constellation, there are 4 subcategories of symptoms under the stereotype behavior constellation. For the diagnosis, a child needs to be demonstrating at least 2 of the 4 categories. The first category is stereotyped movements. So that might be hand flapping or finger flicking. Oftentimes this is bilateral, and sometimes you'll see it up by the eyes. Sometimes a child will even kind of look out of the corner of their eyes at what they're doing. It may also be more complicated movements, repetitive spinning, repetitive bouncing up and down. So those are examples of repetitive motor movements. Repetitive use of objects might be lining up toys, which for a 2-year-old is developmentally appropriate, but you're also looking at like sort of the extent to which the child engages in that behavior, and if they're doing it outside of like the developmentally appropriate age. So a 4-year-old who spends all day lining up objects is different from the 2-year-old who's doing that. It might also be focusing on a part of an object and sort of ignoring the object as a whole. So that might be like repetitively spinning the wheel of a car rather than playing with the car as it's intended. Another possibility is the repetitive use of speech. So there's a few things that we might see. One is immediate echolalia, where the child repeats directly what you've said directly after you've said it, So just kind of like that. Or we see delayed echolalia, which is the child has heard a statement either by another person or on television, and they start inserting that in different parts of their day. Sometimes it can be communicative intent, in intent, and other times not so much. But we call that delayed echolalia when it's sometime later. And then other ways that we might see that are unusual or idiosyncratic words or speech. It might be scripted language that they use. The second category is inflexible adherence to routines or rituals. So we're looking at one possibility is the child might have a very specific routine that has to be done in just a certain way. So an example would be, I've had kids who have evaluated there's one route between house and daycare, and if you go down one different side street, it ruins their day. So this is a very small, seemingly insignificant change in routine that makes a big deal to the child. As far as the ritualized patterns of behavior, these kind of look like OCD, obsessive compulsive disorder type things. So it might be having to touch particular objects in a room before you can kind of go on to do something different, or repetitively washing your hands. It's really hard to sort of tease these out. How are these different from OCD? And it may be hard to sort of discern those two just at a glance. One of the ways that we look to discriminate them is with OCD, usually these things are being done to address an obsession. I am worried about germs, and so I'm repetitively washing my hands. Whereas with autism, more often the child is engaging in these behaviors because they are self-soothing or satisfying just onto themselves. There's not necessarily an obsession that drives them. But that's hard to know, especially in young children. The next category are fixated interests that are abnormal, either in their intensity or in their focus. An example of an unusual focus of attention would be, I had a child who I evaluated who was intensely interested in railroad crossing safety. And he was really into it and knew everything there was to know about every crossing in every part of King County, which ones were to code and which ones weren't. And this is like I forget how old, 8, 9, 10-year-old. So really fascinated with it, knew a lot about it. But I think everyone could agree that's an unusual interest for a 10-year-old. It can also be a totally normal interest, but super intense in its focus. So a child who's 5 years old and loves Thomas the Train, that's not that unusual, but if their entire world revolves around Thomas the Train, I mean everything, like this is their world, that I think we could agree would be unusual in its intensity. And then the final category are sensory hypo or hypersensitivities. That means you're way undersensitive to sensory stimuli or way oversensitive. So undersensitive often looks like sensory seeking behavior, so a child is seeking out sensations. You might see a child who stares at the ceiling fan because they're fascinated by movement. You could also see a lack of responsiveness to sensory stimuli. So a child who falls down and gets hurt, and you would expect them to cry, but they don't seem to react to the pain as you would anticipate. And then you could have kids who are oversensitive. So what this might look like is a child who reacts strongly to somebody coughing. They cover their ears, and they really seem like that hurts their ears to hear a cough. That's different from a child who reacts strongly to a dump truck that's driving through the neighborhood. I mean, something that's loud that would hurt your ears. That's not what we're looking for. We're looking for the extreme. So those are the basics of the diagnosis. Getting into the MCHAT now. So the MCHAT is a screening for autism, and the developers describe it as a two-step or two-stage screening, and it's intended for children who are 30 months and younger, so 16 to 30 months of age. The first stage of screening is a 20-item parent-completed questionnaire. So this is a yes or no questionnaire, and we'll look at that a little bit more in a minute. Based on the way the scoring works is everything that is a yes is okay, unless it's, I might be getting this backward because I always need to look at it, except for there's 3 items that are reverse scored, and those are 2, 5, and 12. Is that right? It'll be obvious when we look at the next page. And so you just add up the numbers of scores. So if the child is supposed to say yes, or the parent is, we're anticipating a yes, but we get a no, that would be considered 1 point. And we just go through and we add up the score. 2 or under is low risk of autism. 3 to 7 moderate risk, and then 8 to 20 is high risk. The instructions state that if the child has a failing score on the questionnaire, the provider is then supposed to go back and do step 2, which is a structured interview focused on the items the child failed. So a child failed 3 items, has a score of 3. The provider goes back using this structured interview and asks those 3 questions, or the kind of the guided interview around those 3 questions. You're not doing the entire, like a 20-question interview, just the questions that were failed. If the child has a score of 2 or higher on the follow-up, that is considered a positive score and would need referral. What I will say about that, so we'll look down here at the predictive power. This particular study was looking at the predictive power of the step 1, the questionnaire, and step 2, the follow-up interview together. There are other studies that have looked at just the first step. Both have similar predictive power. The 2-step being a little bit higher. So for ASD, there's a 47.5% predictive power of the 2 together, and then that's for ASD. And then for any developmental disorder, it's a 94.6% predictive power. So kind of the take-home message here is if a child is failing the MCHAT, that it may not be ASD, but there's a good chance it's something. And so it's worthwhile to refer. And I would argue it's worthwhile to refer even if they fail the first, the questionnaire, but not the second, depending on what you find out from that interview. So you may find out there was a misunderstanding of questions, and as you go through the follow-up, you clarify that. But that's something to consider. The other thing that I would say is if a child on the first step scores 8 or higher, it may be worth a referral, even if you don't go through and do the follow-up. But again, I do think the one piece you want to do, and this is important when we're talking about sort of the cross-cultural use of an instrument that was not developed for Vietnamese families specifically, is that when you get a high or a low score, you just want to make sure that there's some understanding. You have an assurance that the questionnaire is being understood or interpreted correctly. And I think as we have been going through this work, we have discovered there are some challenges with that. And some of what we're going to be talking about next really relates to what are those challenges. I'm not going to get into what the challenges are culturally, but more like, let's presume there are some challenges. You as a provider have to have enough of an understanding of what's sort of behind these different questions so that you can kind of help navigate that cross-culturally. So, and we'll get into that into a minute. Just one last thing. So the American Academy of Pediatrics recommends that general developmental screening using an instrument like the Ages and Stages questionnaire or something comparable be done at 9, 18, and 24 or 30 months of age. And then an autism-specific screening be done at 18 and 24 months. So at Hope Central, like we've been thoughtful about, that's a lot of questionnaires for parents the visits are busy, so how do we balance that? So we elected to move the general developmental screening from 24 to 30 months to make room for that 24-month MCHAT. And Chris, I actually don't remember what we do for the 18-month. Do we just do both? Yeah. So the MCHAT's real important, and so it is important that you make room for it. And you can't rely on the general developmental screener to pick up autism. So it is important that you're using both. So this is the MCHAT, and what I want to say about it is, like, as we've had previous CMEs and we've had some focus groups around questions on the MCHAT and how do they translate for folks from the Vietnamese community, there's been a few thoughts about some questions that could be problematic. To give one example, number 2 says, have you ever wondered if your child might be deaf? And one of the comments we got, I think, Kulam, you actually said this in the previous group, I think, was that perhaps a family from Vietnam would feel uncomfortable challenging the expertise of a physician. They wouldn't presume to know whether their child is deaf or not. That's for a clinician to determine. So they might, out of reverence for the practitioner, say, no, I've never wondered that. And so the essence of the question is being missed. So what I want to try to do here is think about how these different questions track back to the diagnostic criteria so that as you're working with an instrument cross-culturally, you can be thinking about what is it driving at? What is this question driving at? And if this doesn't quite work for this particular culture, is there a different way for me to sort of ask an interview question that might get at the same sort of original intent of the question? Does that make sense? So this is not like, there isn't that I'm aware of, a specific key for exactly how these track back to the diagnostic criteria. I'm just using my intuition here. And there are some that you could put in multiple pockets or multiple places. The exercise is just to see if you can be thinking through how does this relate, realizing there might not be one specific right answer. Does that make sense? All right, so looking at the first one, if you point at something across the room, does your child look at it? Thinking about the diagnostic criteria we talked about, deficits in reciprocal, nonverbal, relational understanding, or stereotype behaviors, which bucket would you put that in? Anyone? Yeah, I mean, could be. Again, like, there isn't a perfect bucket. I decided to put it under the reciprocity one. This is a joint attention question, and so I saw it as reciprocity. But it also is looking at to what extent can a child read gestures. So again, you could put it under multiple buckets. The second one, have you ever wondered if your child might be deaf? So to me, what they're really driving at there is if you call your child and your child does not respond, you might be inclined to think my child might be deaf. So it's really, I think what it's really trying to get at is the degree to which your child is responsive to you. And so if you're wondering if they're deaf, there's a reason for that. So perhaps it's responsiveness. So I put this under deficits in reciprocal social interaction skills. So again, like if you run into the issue of, well, I don't know if they're deaf or not, you're the doctor, you could say, well, what about if you call your child's name? What do they do? So you're able to sort of, get around the cultural barrier and get to sort of the purpose of the question. Does your child pretend or make believe? For me, what this is getting at is social skills. So play is a way that children demonstrate social understanding. So that's where I put that one. Does your child climb on things? I am not exactly sure like how that specifically relates to autism, other than maybe an absence of physical activity shows concern about development. I don't find a clear category to put that in. I'm going to move. I have about 5 minutes. I'm going to move quickly. Does your child make unusual finger movements? I put that under restricted and stereotyped behavior. Does your child point with one finger or ask for something to get help? I put this under deficits in nonverbal communication. They're requesting, and they're using nonverbal communication to request. The next question, does your child point with one finger to show you something interesting? I put that under reciprocal social interaction skills because, yes, they're using nonverbal communication, but for social purposes. Again, this could go under multiple categories. It's more about how do you sort of interpret this for a family who might be struggling with this question. Is your child interested in other children, social relationships? Does your child show things by bringing them to you or holding them up for you to see? This is one of the ADOS things that we look at with the ADOS, is to what extent does a child show objects for the purpose of sharing social interest? Does your child respond when you call his or her name? Similar question to the deaf one. And then when you smile at your child, does your child smile back? This is reciprocal social smiling, so this is a reciprocity question. Does your child get upset by everyday noises? This is a sensory, like to what extent does your child have sensory sensitivities? So that's a restricted and repetitive pattern of behavior. Does your child walk? Again, that's looking at motor development. There is an increased risk of motor deficits with children with autism. So again, this one and the climbing one might be sort of pulling for, are there motor deficits? It's not part of the core criteria for diagnosis. Does your child try to copy what you do? So this is a social reciprocity thing. We expect children to imitate their parents, especially when they're younger. So like when I was shaving one day, my daughter was standing next to me with her fingers like pretending to shave. And so I'm anticipating seeing that in a child. And if there's an absence of that, it may be indicative of some reciprocity deficits. If you turn to your head and look at something, so we've talked about this one. This is, I'm initiating joint attention or trying to initiate joint attention. Does the child respond? So that's a reciprocity. Does your child get you to watch him or her? Also reciprocity. Does your child understand when you tell him or her to do something? That for me is looking at receptive language, which can also be a deficit in children with autism, but it's not part of the core criteria. It's an associated feature. If something happens, does your child look at your face to see how you feel about it? So that's using sort of you as a tool to understand their world, and I see that as another example of reciprocity. You can see a lot of these things seem to fit. Like I would say most of them, they're really pulling for reciprocity as the way to evaluate autism. And then does your child like movement activities? Again, I think what they were trying to get at there was sort of motor development. So that was a very quick review. I don't expect you to have those memorized, and I don't know that they're like, I have the answer for how best to place those categorically. I'm hoping that helps with your navigation when you're working with families who are non-English speaking or weren't born and raised in the United States, to sort of help navigate what we're driving at here. So I have some time to answer questions. Yes.
Oh, thank you. Hi. So when you're doing an evaluation with the kiddo and you're doing maybe, say, the MCHAT or the ADOS, something like that, and you're using an interpreter, do you have any tricks for kind of learning to get the right responses through an interpreter?
Is the question, I heard ADOS and I heard MCHAT. So is the question about both, or? Yeah. Okay. So in my role in the clinic, I am doing more of the specialty evaluation. I'm not seeing a lot of the MCHATs. I think because that is more the primary care side of our organization, and because of sort of the need for primary care to kind of move along, I'm guessing a little bit, but what I imagine typically happens is that the interpreter sits in the waiting room before the visit with the family and works through the MCHAT with them. They bring the MCHAT in, and there may be a concerning score, at which point the physician would use the follow-up, which is an interview, and query about the failed items. And I think that's where you can use sort of the cultural navigation. It's more difficult to do, I think, both in terms of efficiency, but also just like kind of as they're filling it out. I think we just sort of let that roll, and then use the interview as a way to really dive down. As far as the ADOS is problematic cross-culturally across languages specifically, especially if, like, as a provider, I don't speak other languages other than English. So the test developers actually say, don't use an interpreter. The reason being that the ADOS is looking at the relationship that the examiner has with the child, and how is that child responding? Are they responding normally within that relationship or abnormally? And the presence of an interpreter, I mean, it's uncomfortable even as adults at times. So it's a foreign thing to a lot of kids, and they may respond behaviorally very differently via that interpreter. It changes the relationship in a way that we're not really sure how it's going to change it. So is that child appearing autistic because they are autistic, or are they appearing that way because this interpreter is in the mix? With really young children who are, or pre-verbal kids, young children specifically, I guess, who are limited verbal or pre-verbal, I have done those early modules of the or the ADOS, even though there's a language barrier, because those are more heavily weighted on like play behaviors and nonverbal interaction skills. There's still some language that's needed, but I use it as just a method of collecting data, and I usually note in my report that this was done via an interpreter, just to indicate the limitation of how I can interpret the results. As you get an older kid who has, if there's a big gap between their receptive language in their primary language and their receptive language in English, even if they're nonverbal, I probably wouldn't use the ADOS in that situation, because developmentally they're a little older, even if their language is delayed. And so same issue that I kind of mentioned the first time. Does that make sense? In the back?
I'm a medical interpreter and social interpreter, and I participate in many visits and his client, his patients. For my experience, the MCHAT or these questions try to diagnose autism. We need two parents because for some reason I felt something missing in Vietnamese families when only one parent come to the visit and interpreter ask these questions. Some interpreters, they do not feel comfortable and they have the burden of trying to explain things in sight translation. And some interpreters, they do not have a background of medical training. Even though interpreter, the government overboard try to provide training and continue correct education for interpreters, but specify to autism is very difficult. And family, Dr. Tan mentioned earlier, 3 generations of Vietnamese came to America. Now we have 4 and 5th through chain immigrations. And there's came from different regions of Vietnam and different, you have like Chinese in Vietnam and you have Cambodian, Muslim, and all of that. They have a specific stigma, and they don't really share correctly. And there was some family that I personally know that with the autistic kids grow up as 14, 16 now, had not able to service fully. So it seems now is the burden of the physicians, and we need to find the MCHAT to be translated more correctly or more diverse education levels. Many parents, they don't even complete high school, or some families who they let the caregivers or the guardians as grandparents, and which is much more difficult. Autistic kids are being treated unequally in a family, either too much love, and sometimes it's too much neglect. But the parents, they don't know how to navigate the laws in America, and they don't want to admit neglect or abuse or whatever. It's not abuse, it's like different type of love. You can see that the child with autistic in a Vietnamese family, they may have overwhelmed nutrition or obese. That's an example. So I felt that it's a much a burden for a physician to work with a Vietnamese or any culture that they in minority or who newly to America with language challenge as well as medical navigation challenge.
I think one thing to that point that I want to say is that I focused today on discussing the MCHAT. 2 reasons for that. One is it's the most commonly used instrument in primary care in the United States. And 2, because we're currently working to, essentially our research question is to what extent can we use this instrument and modify it or make adjustments in our practice so that it's appropriate cross-culturally. That being said, this is not the only screening tool that exists for autism, and it's reasonable to think about, like in terms of test selection, is there a different means by which I can collect more accurate information for a particular culture group? So as an example, Wendy Stone at UW has an instrument that she developed called the STAT, which stands for the Screening Tool for Autism in Toddlers. And it's sort of like the ADOS in that it's behaviorally derived. You're doing things with the child and you're kind of grading how they're doing on a pass-fail basis. So it's like a short mini ADOS is kind of the best way to describe it. It's play-based. So that relies on your observation and your interaction with the child versus relying on the parent's interpretation of questions that might be problematic linguistically and might be problematic culturally. So there are other options out there. And I use the stat just as another example, so that when you're thinking about cross-cultural work or work with a particular population, what tests are the best tests to get the job done? I think I have time for one more question.
Is the incidence of autism across cultures the same, or are there certain cultures that that seem to have higher rates, or are perceptions of those cultures or perceptions of those behaviors?
I think it's generally similar rates across cultures. There are a few blips on the radar where it seems like there's a higher prevalence in certain cultures. My understanding of that at this point is there's a question as to why. Is this like some sort of artifact of how data was collected within this population, or is there something really different going on here? Vietnamese women who immigrate to the United States, there's been some studies that have shown an increased risk compared to kind of like what's normal, generally speaking, in terms of prevalence. So the higher prevalence among those women, but not Vietnamese women who are giving birth to children in the United States. So again, is there an actual difference there? Is there some sort of difference in data collection? I think we're still trying to sort that out. I think my time is up.
We have time for one more question.
One more question.
I'll be really quick too. As a speech language pathologist, I was looking at the MCHAT and the English wording in question 2, where you use the word, have you ever thought that your child might be deaf? And the word deaf implies that they can't hear anything.
Yeah.
And I think most of us have seen autistic kids who, when you call their name, they don't respond. But as soon as the doorbell rings or the phone rings, they turn and look. So that question could be worded differently.
Yeah, so
Maybe
there's
hard of
problems with the
hearing
wording
or
even.
low hearing or something like that. And then secondly, how much time elapses from the time of initial administration of the MCHAT and then the follow-up interview?
I think that ideally it could be done at this. Patricia, do you want to answer that one? Yeah.
I don't know if the other primary care, I'm Patricia Scott, I'm one of the doctors at Hope Central also. I don't know how many of you all who do primary care use the MCHAT recall.